Okay. I told Yaelin and Air before, I'm going to need about 2.5 hours to talk about the things I want to talk about. Unfortunately, I'm going to have to keep it at 15 minutes, which I'll try to do. So I do want to say something about the debate about empirical knowledge or data that has been here in the room for the past couple of days, and Nair spoke to this before, and Eva did yesterday. And I wanted to share a few of my thoughts about this. I guess I'm one of the people who believes that there's not one way to know things. So the empirical system and science creates knowledge that I think is very, very valuable to us. And it's a form of knowing, a way of knowing that's very, very helpful. But it's also not the only way we know things. We can know by using different processes as well. And other ways of knowing don't detract anything from the scientific method, nor does the scientific method detract anything from other ways of knowing. And I really think that as therapists, we should be using all the knowledge that we can get, whether it's empirical or non-empirical. And using anything I can get my hands on to help the patient is what I'd really like to be doing. I also think that different types of knowledge really do a better job at answering different types of questions. So the way I look at empirical knowledge or scientific knowledge is that it's really, really good. It's also designed to answer general questions, broader questions. It can never, ever tell me what to do with a particular patient of mine in a particular moment. It's not designed to do that. But it does tell me what works for most people most of the time, which is what it looks into. And if I want to make sure that I tailor things to my specific patient, I'm going to need additional knowledge, or my clinical experience, or my understanding of the patient today, the mood they're in, things like that I'm not going to get from science. But I also have to start somewhere. And that scientific knowledge is so, so important to be able to get a general direction. Sometimes I think of it, I don't know if it's a really good metaphor, maybe you'll suggest a better one. Mine sounds lame. But I sometimes think of it as, I think of the people who flew here from another country or came here from another country for the conference. You used more than one means of transportation. You took a plane to get to the country, and then maybe you took a cab to get to the hotel. One form of transportation brought you to the general vicinity of where you need to go. And then the other form of transportation answered a very different need of going within that country until you reach the specific hotel you needed to get to. And I sometimes think of it in that way, as research being the plane for me and guiding me in general to the country I need to go to the area. As soon as I have a formulation, for me it lights up all these different, possible interventions, or a certain disorder, or places I would like to go, and then I need to tailor them to the specific patient, and I do that mostly, sometimes using scientific knowledge, but a lot of the times using additional knowledge as well. And trying to get here from another country using only a taxi would be disastrous, as well as trying to fly directly to your hotel. That wouldn't work either. But if you combine these two well, you could get anywhere. So again, not sure if it's a great metaphor or not, but I keep feeling I want to use more than one type of knowledge. I think it says something about dialectics, the way John was talking about, different ways of knowing that might have tensions between them, but using them both. And it has something to do with what Monica talked about having multiple parts of the self, maybe multiple forms of knowledge or in the external world that I can tap. So just wanted to share my thoughts. To me personally, I think our biggest problems are when we start to reject one form of knowledge and claim that only one has any validity. I think that's more problematic than being open to different ways of knowing and utilizing anything we can to help our clients. The other thing I wanted to talk about, and has been mentioned in various ways, is this idea. I think not understanding this completely is something that contributes to these misunderstandings and clashes between different theoretical orientations. Our theoretical orientations are just the ways that we think about people. Our patients, but people. So I can think about my patient in cognitive behavioral terms, in psychodynamic terms, and in many, many other terms. But sometimes we all make this mistake and think that the way we see the patient is the patient. That our patients are psychodynamic, that our patients are cognitive behavioral. We lose this, in my opinion, very, very important separation between the way we think about people and people. Now, the reason I say this is I teach a course on CBT in our graduate program, and every year I do it, I encounter misunderstandings about this gap. So students would tell me, but Idan, this client, they're talking about their mother. It's psychodynamic. And I keep telling them, I don't quite think so. I think the client is talking about their mother, and it's a very human thing to do. In general, we all have mothers. The client's mother doesn't belong to psychodynamic therapy. It's just the client's mother. And I can understand that relationship using psychodynamic, terms. And I can understand it using cognitive behavioral terms just as easily. So the thought that, patient content is psychodynamic or cognitive behavioral, it always sounds wrong to me. I can think about it in so many ways. And I think so much of what has happened here has to do with that. So Jonathan brings this idea up, and somebody else says, well, it's Kleinian, right? But it's because it's something that happens in the real world, and I can look at it through a whole bunch of different terms and different orientations. And I think remembering that is something that could help us as a profession improve the way we talk to each other, or facilitate discourse, because the way I see things is not the way they actually are. It's just the way I choose to see them, or at least there's a difference there, right? Our biggest problems are when we think we have the one and only truth and everybody else has it wrong. So I just wanted to say something about that as well. I think that's one of the barriers to integration that I keep running into. And maybe I'll say one last thing about another issue that's been raised here a few times, and I'll just share my thoughts about it. I think another question that we've been talking about a lot is what is the role of the therapeutic relationship in treatment? And there are multiple answers to this question. It's very clear to me that one possible answer is that the therapeutic relationship is the active ingredient in treatment. This is what helps patients get better. The relationship, or as Monica said, maybe the therapist himself or herself, their personality. So personality / relationship. You put it so well. I've never heard that belief encapsulated so succinctly and precisely as when you said, therapist as medicine. You said it, and it was like, it's a really nice way to kind of encapsulate that belief. And then I think there's another way to look at the therapeutic relationship, and that's as a facilitator of other types of interventions. So when I have a good relationship with a client, we can do other things, additional things that are going to help my client. I see it that way sometimes when we do exposure. My clients would never do exposure with me if we didn't have a fantastic relationship. Like, it would never happen. So the other way of seeing it is alliance as a facilitator of other interventions. And I think the psychodynamic orientation usually focuses on that first way of seeing the relationship, or emphasizes that part of the relationship as curative. And I think maybe the CBT part would emphasize that second way of looking at things. But actually, these two ways, they're not mutually exclusive, right? They can happen together. So the relationship can be helpful on its own, and it can facilitate other interventions that help my clients. And I think sometimes some of the problems in our discourse is when we treat it in these different ways and seemingly can't talk together. But ultimately, I think we all know that both of these things happen, all the time. So just, I'll share one last thought about this, and maybe you'll think differently, but to me, the way I see it is that the more relational a certain patient's problems are, the more that first way of seeing things, like the relationship as a curative factor, the larger a role it plays. And the more that clients' problems are not very relational, I'll give you examples, then the less of a role that plays. They're always both there, but it's just the relative importance, to me, keeps shifting. So if I have a client with borderline personality disorder, that's super relational. I can't think of any other form of psychopathology that would be more interpersonal than that. Then the therapeutic relationship would play a huge curative part in and of itself, in my opinion. But if I have a client with OCD, that seems very, very different to me. The way I see it, the relationship in and of itself would play a lesser role in that treatment, whereas the second way of viewing it would play a larger role in that treatment. Relationship is facilitating other types of interventions. So just wanted to share that thought. Maybe it's not true, I don't know. But it's the way I see things. And I think that's about it. Thank you, guys.
Think how many times patients come in to if you think how many times patients come in to see you, they're all different, right? So somebody's coming in, they say, I'm really here, I want to deal with this. It's like the last thing they want is to have a goddamn relationship with you. They want something to take away. Others, of course, when I say that, I don't mean that you're not going to be interpersonally, sensitive and show a decorum and that they feel comfortable. But it's true. There's a lot of people that just want to get better. and they want something immediate, and that is the most important context versus those who, come in and require long-term work. So I just wanted to validate your point.
Sure. And I just want to say that you said everybody's different, and just as a slight twist on that, I'd say every patient is both similar and different to other patients, right? Each of them,
And to themselves. And to themselves.
And to themselves, right? Because it's always that dialectical thinking that you were talking about.
I think that with OCD patient, maybe he won't see you in the beginning. It's very obvious. But in the second phase, I believe he needs to communicate. He needs to see you. He needs to feel your subjectivity. And this is part of the curation of therapy, in my opinion, for this OCD guy.
Everything is relational. Yeah. The only question is it only relational? I don't know.
So just,
Sure.
I've been thinking and studying the Alliance in particular for many years. And just a slight academic point, Freud himself did not see the relationship as curative. He saw it as exactly what you described CBT looks at it as. All right, so at least from a more traditional, classic analytic point of view, the interpretation is the mechanism of change. So it's mixed, but it's definitely not interpersonal the way that a lot of current psychoanalytic theory tends, right. And it's been looked at, do people who have more interpersonal problems benefit more from the Alliance than people who have less interpersonal problems? And I was holding that for a long time, but it doesn't really work out in the literature. That the Alliance is not more predictive of outcomes in borderline personality disorder versus
Right.
So it doesn't really work out that way.
But can I make my point clear? Actually, what you're saying is not contradicting my point, because I didn't say that the Alliance would predict outcomes more in borderline versus OCD, just that first view of the Alliance, that pathway, one of the two pathways leading from Alliance to treatment outcomes, would be stronger than the other pathway. So that's not the same finding. Yeah.
Okay.